Next, let's look at a little more detail about how the pupillary light reflex pathway works and which smooth muscles are under direct control of this pathway. Fundamentally, this is an example of several bilateral cranial nerve reflexes, whereby a sensory stimulus of sensory fibers in one cranial nerve bilaterally innervates motor fibers in two cranial nerves. Obviously, one on the side of the stimulus and one on the opposite side. So the anatomy of this reflex looks like this. When light enters an individual eye, it stimulates retinal ganglion cells. The impulses travel up cranial nerve to the optic nerves, which are the axons of those ganglion cells. Note that the optic nerve and subsequently the optic tract axons project bilaterally into an area of the midbrain immediately adjacent to the superior colliculi that's known as the pretectal nuclear region. And then, as you see in the diagram on the left, the pretectal nucleus neurons then project bilaterally to the preganglionic parasympathetic neurons that are found in the nuclei of Edinger-Westphal, which are also situated in the midbrain. So the Edinger-Westphal nucleus, containing those preganglionic parasympathetic neurons, then project out to the ciliary ganglion that's not shown in the diagram, and the postganglionic parasympathetic neurons then go to innervate the constrictor of the or sphincter of the pupil, causing pupillary constriction or miosis. Next point we want to make is outside of the parasympathetic pathway, we said that basically the smooth muscles in the eye are under either a sympathetic or a parasympathetic control. So what you see on this chart are the two smooth muscles that are under parasympathetic control. They are the constrictor or the sphincter of the pupil and the ciliary muscle. The ciliary muscle, as we'll see, is involved in allowing us to change the shape of the lens in response to change in depth of field, a phenomenon that's known as the near response or the accommodation convergence reaction. Note that the parasympathetically innervated muscles, as we indicated in the pathway previously, utilize a form of a muscarinic receptor. And obviously, if there were a receptor blockade, you would not be able to constrict the pupil. The result would be pupillary dilation and basically a loss of the ability to accommodate in the near response. The sympathetically innervated sphincter of the eye is the dilator of the pupil. It's under control of alpha receptors under sympathetic innervation, and obviously a receptor blockade of that receptor would cause a constricted pupil as a result. Finally, the ciliary body epithelium, which we noted earlier is the source of aqueous humor, basically in the posterior chamber, it is under sympathetic stimulation. So patients, for example, with glaucoma will likely be utilizing a beta blocker, basically, to reduce aqueous humor production because they're having a drainage problem at the level of a canal of Schlemm. Next is an extension of the light reflex that not only involves pupillary constriction, but is the sum total of the three events that go on in the so-called near response or accommodation convergence reaction. So fundamentally, when an individual is focusing on a nearby object after looking at a distant object, three things occur. The accommodation process is where the parasympathetic axons contract the ciliary muscle, and in effect that has an indirect effect on the lens because ciliary muscle contraction actually relaxes some structures called the suspensory ligaments. And when the suspensory ligaments are relaxed, it allows the lens to round up, increase its convexity for near vision. That allows us to change our ability to focus on an object whose depth of field has changed. But that's only the first process. The other processes that occur is in response to a decrease in depth of field, both pupils will constrict, and as you focus on an object that's approaching your face from a distance, both medial rectus muscles contract, causing adduction of both eyes, a phenomenon that's known as convergence. So the point is, the accommodation convergence reaction utilizes not only parasympathetic axons associated with cranial nerve 3, but also the skeletal motor axons that provide a mechanism to bilaterally contract both medial rectus muscles and adducting both eyes so that you can properly focus on a nearly approaching stimulus. Next, there are a wide variety of pupillary light reflex abnormalities, some of which we've discussed in previous chapter reviews. One of them is an Argyll-Robertson pupil. These pupils are commonly seen in patients with late-stage neurosyphilis and tabes dorsalis. They can also be a component of a diabetic neuropathy. But in essence, what happens here is that in an Argyll-Robertson pupil, there is a diminished or lost bilateral pupillary light reflex. In other words, the pupils will not constrict bilaterally to light, but the accommodation convergence reaction, the near response, tends to be preserved. The lesion where we get the demyelination associated with this occurs, we think, in the area of the pretectal nuclei. And the reason we get the pupillary abnormality in this case seems to be that if the neurosyphilis affects an equal number of axons and they're myelin, presumably there must be more axons devoted to the accommodation convergence reaction than there are axons associated with the direct or concentric light reflex. Then, if a patient has an optic nerve lesion, again a common feature to multiple sclerosis, they will develop what is known as a relative afferent pupillary defect, known as a Marcus gun pupil. In this case, when you have an afferent defect, there's going to be a diminished light reflex on the eye in which you are shining the light, because you have obviously limited the ability of that optic nerve to reach the pretectal nuclei and therefore limited the ability of the pupils to respond by constricting fully in response to light. So the point that we make on here is that when you shine light in an optic nerve lesion pupil, the pupils will not constrict as fully. They'll have a less brisk pupillary light reflex. But you can evaluate this patient by performing what's known as the swinging flashlight test. For example, when you shine light in the normal eye, basically all components of the light reflex will be intact and the pupils will constrict fully. But when you swing the light source to the affected eye, the pupils, instead of constricting, they will paradoxically dilate because suddenly the central nervous system perceives that less light is available. So the swinging flashlight test is one where you shine light in the normal eye, you get bilateral pupillary constriction. When you immediately shine the light to the affected eye, the pupils will not maintain their pupillary constriction. They will paradoxically dilate. Then, a couple other pupillary abnormalities. Horner syndrome, we know, is a lesion in any number of places that disrupts the sympathetic innervation of the entire face, scalp, as well as the orbit. And typically, if the lesion occurs in the peripheral nervous system, it affects a preganglionic neuron that's arising from the T1 spinal cord segment, or it affects the postganglionic neuron or the superior cervical ganglion, which contains their cell bodies. And typically, a Horner syndrome patient is always going to have an ipsilateral meiosis, ptosis, and hemianhydrosis, regardless of where the lesion is. But recognize, even though it's not pointed out on here, that if there's a lesion in the T1 to superior cervical ganglion pathway, that'll cause a peripheral ipsilateral Horner syndrome, whereas a patient that lesions the descending hypothalamic axons that course from the hypothalamus down to the T1 spinal cord segment will have a central Horner syndrome. And certainly the way you can distinguish where the lesion is will be not so much on the Horner syndrome signs, but on the presence of other neurologic signs and symptoms that tell you that the lesion is either inside the CNS or outside the CNS. Next, two more. An Adie's pupil is a dilated pupil that, again, is like one with Argyll-Robertson signs and symptoms, but it's a unilaterally dilated pupil that, again, responds sluggishly to light, but much better in accommodation convergence. And this is classically associated with a lesion of one or both ciliary ganglia. It's more commonly seen in women, and it's also associated with suppressed knee jerks or suppressed muscle stretch reflexes. And then finally, classic cause of unilateral dilated pupil is a patient that has a uncal or transtentorial herniation where they probably had some sort of intracranial increase in pressure, usually a hematoma. And what that causes is it compresses the lateral aspect of hemisphere, causes the uncus, which is the most medial aspect of a temporal lobe, to herniate. It'll compress the third nerve on a corresponding side, causing initially a dilated and fixed pupil. Later on, it might cause a weakness of adduction and a down and out eye, along with a skeletal muscle generated ptosis. But note that the initial presenting sign of an external compression of the oculomotor nerve is virtually always a dilated pupil, because the parasympathetic axons of cranial nerve 3 run on the outside of the oculomotor nerve. Now let's extend our conversation to look at the structure of the retina as we begin visual processing. Note first off that light entering the retina must pass through the ganglion cell layer, the internuclear layer, the outer nuclear layer, because the only light-sensitive part of the retina are the outer segments of rods and cones, which are situated way over on the left side of this picture. That's where the phototransduction process occurs. Note that the outer segments of rods and cones are closely associated, in fact, in many cases, embedded in a specialized epithelium called the pigment epithelium. Pigment epithelium is very important because it takes up nutrients in the form of glucose and vitamin A out of choroidal arteries and transports them to serve the outer segments of rods and cones. So in an individual that suffered head trauma and a detached retina, the site of the retinal attachment is most commonly at the area where the outer segments are embedded in the pigment epithelium. And if they're not reattached surgically, that portion of the retina will degenerate due to lack of nutrients. Now, the visual system is very similar in a number of ways to other sensory systems in that, again, it's going to utilize fundamentally 3 neurons to get visual information from its photoreceptors, rods and cones, to conscious levels of visual cortex. And again, it's going to be similar in that the axons of the second neuron in visual processing will cross the midline, much like axons of other sensory neural systems did the same. So first off, let's make a distinction about rods and cones. Cones we've already seen. They are specialized for visual acuity and color, and obviously they were concentrated in the fovea, where we analyze basically what an object is and what its color is. Rods are distributed widely throughout the rest of the retina, except in the fovea, and they are sensitive only to relative light levels, shades of black, white, or gray, and they're also motion sensitive. So when you want to track a moving object across your visual field, you're going to use the rod system. When you want to analyze what an object is or what its color is, you're going to use the cone system. All right, so let's look now at what the identities are and where the 3 neurons are that are fundamentally involved in visual processing. So it turns out that the first 2 neurons involved in visual processing are in the retina. And you can see that illustrated here, where synaptically the photoreceptors interact with bipolar cells, whose cell bodies are in the internuclear layer of the retina. That's neuron number 1. The second neuron involved in visual processing are cells in the ganglion cell layer. As we've already indicated, it is the axons of those ganglion cells which now represent the second neurons of a 3-neuron visual processing pathway that leave the corresponding retina in an optic nerve. So since the retinal ganglion cells represent the axons of the second neuron in a visual processing pathway, it is these axons that must do 2 things. One, they're going to project to a third neuron that's going to be found in the thalamus. And second, the axons of the optic nerve should cross the midline if they are typical of other sensory systems, and they will. So note that the major thalamic projection of the optic nerve axons is to neurons in the lateral geniculate body. But as we've indicated, that's not the only destination of optic nerve axons. Those that participate in the light reflex must also go to the pretectal nuclei. And even though it's not illustrated here, we know that a nucleus in the hypothalamus, the suprachiasmatic nucleus, is also going to be a recipient of optic nerve input.